Good evening. Hello. Good evening. Hello. Can everyone hear me? How's the volume sounding? Better? Sounds great. Ah, lovely. First of all, I just want to extend a warm welcome to everyone attending this evening. We really are we are overwhelmed by the turnout, and yeah, please just a round of applause to everyone for coming through tonight and showing interest in such an important topic. So I'm going to start off with just a few housekeeping things, just because I'm scared I'll forget it if I don't say it straight away. So just to let you guys know that this evening's talk is being recorded for some students who weren't able to make it and who have requested it. So I just need to let you guys know that for consent and whatnot. So if everyone's happy with that, we'll move forward. All right. No, objections? Okay, cool. I didn't hear anything. All right. So tonight's event is provocatively titled Changing Sex, and it is a talk on, or it was proposed first as a talk on the medicine, surgery, and psychiatry of gender affirmation therapy. Unfortunately, one of our first speakers for the evening, Dr. Adele Maria, was unable to make it, but stepping in at the last minute and really saving the day have been the team from Gender Dynamics. And yeah, they've really pulled through for us, and they're gonna be telling us a lot of exciting things this evening. I also would like to thank my collaborators for this evening. So the Surgical Society have come together, the Gender Dynamics team, and the Internal Medicine Society. And I hope our working together can serve as some sort of example for more collaboration in healthcare. As many of you in the audience will know, the multidisciplinary team is one of the principal features of the primary healthcare philosophy. And unfortunately, it's something that's not often realized in the structures of medicine. One area where we think it has been utilized really well is the Transgender Clinic at Groote Schuur Hospital, which sees this conglomeration of social workers, psychiatrists, endocrinologists, nurses, plastic surgeons, and the patients themselves all coming together to offer a really valuable service. Now I'm going to hand over to my colleague Matthew Potter from the Surgical Society, who will be introducing the team from Gender Dynamics. Thank you.
Evening, everyone. I'm just going to be outlining our very packed agenda for this evening. So to start off with, as Rowan mentioned, the team from Gender Dynamics will be setting a foundation for this evening's discussion by outlining a few of the factors that transgender people in South Africa experience on a daily basis, with particular focus on the support structures that contribute towards improving the understanding and the advocacy for the transgender community within South Africa. First up, we've got Estienne Smith, who's been an integral part of setting up this event this evening and putting me in touch with this vast body of supportive and really contributing to the overall well-being of the transgender community in South Africa. So Estienne from Gender Dynamics will be addressing the trans depathologization and legal rights. Sorry, even I'm adjusting to it. Next up, we have Linda Shimane of the Health Advocacy Office, who will be speaking briefly on the growing support structures for the transgender community in South Africa. Following that will be Simon Pixton Taylor, who is a psychiatrist at Red Cross Hospital and works with transgender adolescents, and who was also part of the GSH Transgender Clinic team. And finally, we have Neil Victor, who will be discussing the Psychological Society of South Africa's new guidelines on gender diversity. So without further ado, I'd like to hand over to Estienne. Thank you so much for being with us this evening. We really look forward to what you have to say.
Can you hear me? Okay, thanks very much, Ruan and Matthew, and the UCT Surgical Society for inviting us to speak here tonight. It's absolutely great to see a hall full of UCT students and I hope lecturers and academics here. It's a great opportunity for us to be speaking to you. I'm going to give a little bit of, start with a little bit of just an overview of a number of, I think, key concepts and ideas that we need to have in mind before we even dive into gender-affirming healthcare. And excuse me, I've got a bit of, leftover flu, so not that great. My voice is not that great tonight. But perhaps just to also say one or two things about myself. And I think within the trans and gender diverse community, it is very important to recognize and respect people's own gender identities, the way they identify themselves, and the way in which they want to address via pronouns, titles, the gender they identify with. So generally when we start introducing ourselves, we will mention our pronouns, and in my case it's either they or he, they being a gender-neutral pronoun. I've got a long history of trans activism from about 2000 onwards. I cannot say I identify really as male or female, but I'm probably more on what one would call the trans-masculine spectrum. But ultimately, I think I'm just me, and I think it's important to recognize there's a wide spectrum of gender identities. So to start off with, just saying who Gender Dynamics is. So we're a transgender human rights organization. We're based right here across, very close to UCT, in Ops, right next to the bridge, Station Road, so you can come and pop in and say hi if you want. We've been founded in 2005, and we basically work nationally and regionally and internationally, regionally especially in Southern Africa. And our focus is on, because we're a human rights organization, is on advocating for human rights and social justice for trans and gender diverse persons. And we use community mobilization, media engagement, public education, research, and training. And we currently have 3 main focus areas. The one is healthcare access, which is basically general and gender-affirming healthcare access for trans people and gender-diverse people. This does not mean we provide those services. Linda can tell a bit more later on, and Elma de Vries can also maybe mention a few things about the training. Elma's on our board, and she's also on the Groote Schuur Health Trans Clinic. So we've got a number of people here who can give inputs. But so what we've been doing is training healthcare providers. We've been advocating for greater access, both general healthcare, like when I've got flu and I need to go to a clinic or a GP, to access healthcare without stigma and discrimination, but then also more specifically gender-affirming healthcare services, which is what the Groote Schuur Trans Clinic team is doing. You will see there's booklets at the back, which are some of the publications that we have been publishing to help to train healthcare providers in the issues. Actually, I've got a number of things that I can show you here. The second thing is education. We're both in basic education and in higher education. We are also training providers, teachers, and also at the moment looking at higher education institutions like UCT. We'll probably come around here as well. To basically look at institutional transformation. Do our trans and gender diverse students' rights and needs basically taken into account and provided for in institutions? But then also looking at particularly training of teachers in gender identity and gender expression issues. This is pre-service teachers who will go on to teach in schools. Then in law reform, we're looking at a number of issues, among others, which I will speak a bit later more on, is legal recognition for trans and gender diverse persons. This is changing your legal gender in your ID. If you just give me a moment. So I think in terms of healthcare access, we've produced, for instance, our hormone booklet, basically assisting GPs on providing hormone access to trans and gender diverse persons. And once again, Elma de Vries, who doesn't want to be mentioned, but is very available to help and guide anyone who wants to provide healthcare access. She's one of the authors of the booklet. Then we've got the booklet at the back, which basically also says what gender affirming healthcare entails. And in terms of the education work that we're doing, we've produced a gender identity and gender expression manual, which I think is generally quite useful to look at in terms of both educating students and teachers and other providers on what gender identity and gender expression issues entail. And then in terms of our law reform, we've produced publications on our issues with legal gender recognition and the struggles that we are having with home affairs. I'm not going to go into too much detail about that. Then perhaps just to move over to gender affirming healthcare. And I see the topic of tonight was framed changing sex, as you said, like very kind of provocatively changing sex. And I can imagine that's part of what drew people here. And also mentioning that it's about gender affirming therapy. Now, I think we don't, even though perhaps in public media and so on, we speak about sex changes and changing sex, generally that's not really the way in which we speak anymore, especially not within transgender advocacy. We speak more about healthcare that enables a person to affirm or express their gender identity. Rather than this idea of changing a body completely from like one sex, which is, for instance, male, to another sex, which is biologically completely female. Those kind of assumptions are not true. So, and for us, the main thing is to affirm a person's gender identity. So it's about their own gender identity, where the focus is, and basically providing them with the healthcare services that will affirm their gender identity, rather than to focus on this changing the sex of the body. Also keeping in mind that there are many trans and gender diverse people who don't necessarily want to make changes to their body. There are many of them who just want to be affirmed in our gender identities and gender expressions without having to make any changes to our bodies. And many who also, perhaps for health reasons, cannot access or cannot undergo gender-affirming surgeries or start taking hormones. So changing sex is putting it a little bit too narrow, and often there are mistaken assumptions going with it. So, and I think in terms of gender-affirming therapy, we try to speak a little, to shift the focus a bit in advocacy to gender-affirming healthcare as the term, rather to assume it's a kind of a therapy and that there's something to be cured. I know that's often the assumption of within healthcare professions, that there need to be, an illness or something that needs to be cured. But I think for us the focus is more on wellness and facilitating the services that the person needs to affirm their gender identity. So we want to frame it in a more positive and affirming way. And then just to say that, obviously gender-affirming healthcare, as you will probably hear again tonight, it could include any of a combination of psychosocial support, hormones, different types of surgeries, other treatments and procedures like hair removal, laser therapies. But those things are all available range of procedures that any particular person may or may not want to pursue. So some may want to pursue none of those, some may want to choose one or a combination of them. So each individual is different, and that is also what you will see in the World Professional Association for Transgender Health, WPATH. Their latest guidelines also emphasize that it's very individual and unique what a person may want to access or what they may need. And then lastly, and I think this is extremely important, that it is healthcare that's provided on the basis of full, free and informed consent. And I think there healthcare providers play a very important role. It's the person's own decision. It's not for healthcare providers to play really an assessing or a gatekeeping role, but to provide all the information that a person would need to make a free and informed choice. And I think, although tonight is not about intersex persons, it is very important to know that sometimes gender-affirming healthcare is confused with what is being done to intersex infants and children, which is not gender-affirming healthcare, because those are different, often the same or similar kinds of procedures, but it's without the possibility of free and informed consent. But we'll get perhaps a bit more to that later. And yeah, you don't necessarily have to look at all that. I just put those terms up, and I think it's because there's so often a confusion of what it is to be a transgender person or an intersex person or even a gay or a lesbian person. Often all these different issues and people are kind of lumped together under one alphabet soup, LGBTI+, QIA+, but it often then invisibilizes the differences and the different needs and the different human rights at stake. So you will see that ugly long acronym at the end, which I don't even know how to pronounce. Perhaps someone can tell me. Initially, it just started with SOGI or SOGI, which means sexual orientation and gender identity. But then people realized that we needed to add gender expression and also sex characteristics. So you'll see advocacy also evolve, like any kind of knowledge evolves. We realized that certain people are excluded, and we added on the concepts to help deal with those human rights issues. So sexual orientation is then sexual, romantic, emotional attraction to the same gender, and you will notice I say gender, not sex, because it is about how you yourself identify rather than what may be in your pants. So it's about your attraction to the same gender, a different gender, several genders, or no gender. So if you think of terms like bisexual and you think of terms like gay, straight, pansexual, those are generally the terms that describe people's sexual orientation. Gender identity then is how you yourself internally, if you think about how do you identify yourself? Every person has a gender identity. So how do you identify yourself internally as female or male or an alternative gender or a combination of genders or not having a gender? So again, it's a spectrum. And then whereas gender identity is what you yourself internally identify with, gender expression is how you express it externally. So it's basically what other people will see when you talk, when you dress, what your hairstyle is. Oops. And it's not so much your physical body as such as what you put on it and how you use body language, mannerisms to communicate and to express your identity. Then sex characteristics brings us to the physical body. And that is basically your anatomy, your physiology, your chromosomes, your biology, your basically what your physical body looks like, and particularly then related to sexual or reproductive kind of functions or activities. So we will say that those present at birth are the primary sex characteristics, like the genitals and the gonads, and those developing in puberty and throughout life is then secondary sex characteristics, as many of you will know. So breast may start developing, some facial hair, all kinds of things change in your body. So are there perhaps any questions about these? Because I think what we are speaking tonight mostly here in terms of trans and gender diverse issues is gender identity and gender expression. But when we speak about gender affirming healthcare, we want healthcare that helps us to affirm our gender identity. And for many of us, not for all of us, for some of us, this means changing sex characteristics, which is the physical body, but not for all of us. But are there any questions about these distinctions? Anything that's not clear? And then perhaps just a few of these labels that we are using. So transgender or trans, we say it's a person whose gender identity differs from the gender that was assigned to them at birth. So when you're a baby, you get assigned a certain gender. And for many of you, if you think first, what is your own gender identity? And what was assigned to you by your parents, by your community, by the school, by by the doctor when you were young or when you were born. Think of what gender society assigned to you, and think of what your own gender identity is. And so we will say that a transgender person is a person whose gender identity, the way they identify themselves, is different from the gender that they were given at birth socially. Whereas a cisgender person is a person whose gender identity is the same as the gender assigned to them at birth. So let's say you were born and your parents said, this is a little girl, and you grew up and you think of yourself, or you identify yourself as a little girl and eventually as a woman. Then you are a cisgender because it is the same as what you were assigned at birth. But let's say you were born and your parents and everyone said, this is a little girl, but inside you, either very early on or later in life, you feel like you are a little boy or you are a man. So your own gender identity is different from what others assigned to you. Then you are transgender. And then just a couple of things to just perhaps keep in mind when we think of how trans and gender diverse people move in society and the obstacles and challenges we face. And I think Linda will speak a bit more about that. But the important concept we use is cisnormativity, which is the assumption that all people are or should be cisgender. In other words, the assumption that every person should accept and identify with the gender that was assigned to them at birth. That is cisnormativity. And then transphobia would be an irrational fear or hatred of trans people. And I'm not an expert on intersex issues, and there may be some intersex people here who may want to actually take over the slide. But I think it's important to distinguish transgender and intersex because often people confuse the two, and it's then to the detriment of intersex people. So an intersex person is a person who is born, and it's very important to see that born. So already at birth, they have sex characteristics, could include genitals, gonads, chromosome patterns that are more diverse than dominant social constructions of male and female bodies. Generally, when a child is born, people assume it must be a typical male little body or a typical female body. But sometimes children are born who cannot be that easily classified as female or male by looking at their very physical bodies. And those children are then intersex. And sex binarism is then exactly that assumption that female and male are the only two existing sexes, or at least the only two really normal sexes. And that frankly, if you are born with a body that does not look typically male or typically female, there's something wrong with you that needs to be fixed. So that's a problematic assumption, and this assumption often leads to, in medical settings and in cultural settings, to what is called intersex genital mutilation, or IGM, which is similar to female genital mutilation, but in this case, it is then that once people see this baby or this child is there whose body doesn't look female or male, typically female or male, they want to change it. They want to, even though it may be a perfectly healthy body, they may want to do surgery on it. I'm running out, am I? Okay, cool. Okay.
I'm not trying to rush this speech.
Okay.
Just have
Thanks. Okay, 2 slides to do. 2 slides. So I'm just going to jump. I mean, we can spend a whole evening on this, but just perhaps to say a little bit, and I'm sure Simon and perhaps Neil might have more to say about this. But when we speak about gender diversity, then we will see that we've got diagnostic manuals, as I'm sure many of you very well know. One is for mental mental health issues or mental disorders, mental and behavioral disorders, which is the American Psychiatric Association's DSM, and the other one's the World Health Organization's International Classification of Diseases. Now, there has been a lot of advocacy by trans people across the world to remove a diagnosis, a gender diagnosis, for us, and specifically because that particular gender diagnosis was a mental illness diagnosis. Or at least to change the diagnosis so it's no longer a mental illness one. So what we had is that obviously in the DSM, which is purely mental disorders, there's just been a shift to more acceptable language from gender identity disorder to gender dysphoria, but it remains classified as a mental illness in there because that's all the DSM has. The ICD, on the other hand, as you know, include both mental but also all other medical issues. So there, it used to be in the mental illness chapter, but it's been moved now in the latest version, the ICD-11, which is still to be formally adopted, but it's been moved from a mental illness classification to a sexual health condition chapter. So that was great progress made through advocacy and research and a lot of education around the issues, so that it is now no longer seen as a mental illness, but more as a sexual health condition. I think for many trans and gender diverse people, especially activists, it would be great if we could completely remove any diagnoses so that we are no longer seen as ill or having a condition in any sense. But unfortunately, diagnoses are strongly linked to access to healthcare, particularly gender-affirming healthcare. So if we remove all diagnoses, especially in countries who do have great access to gender-affirming healthcare and do so on the basis of an ICD diagnosis, if we remove those diagnoses, they will also lose access to healthcare. Now, there's been different arguments about what to do. Okay, it's progress. Don't see it as a mental illness anymore, see it as another kind of condition. But what about, let's say, seeing it as something that requires healthcare services, but is not an illness? Let's say like pregnancy or abortion, a healthy pregnancy or abortion that someone wants. So seeing it, framing it in that way and seeing it as a trans healthcare block or gender-affirming healthcare block with codes that you can claim for, but that's not seen as an illness. That is one option, but it is still a struggle to even get there, because I think if we look at what gets funded, and not all codes get funded. So there are some codes that are more likely to get medical aid coverage, to get governments to provide them. And there's, in other words, a cautious move by trans activists not to completely remove these diagnostic codes, even though it does have implications for how we are viewed in society. Yeah, I think what can happen and what has happened in some countries is that they have made country-specific adaptations to the ICD. Some countries, I think Norway has, for instance, removed the diagnosis and said it's not an illness. So that is possible, even within South Africa. But then one needs to know that if you are going to push for not making it a diagnosis, you will have to advocate and mobilize very strongly to make sure those services are still provided in some way by the state. And as we know, and as others will say, we have very little available as it is. So the National Health Insurance, as you know, is coming. I think it makes provision for mental health services to be covered, but not for sexual health yet. So there is a concern that if it's, now that it's in the sexual health chapter, what will happen? So again, we need allies among healthcare providers to help us motivate and push for our services to still be provided and expanded. My last slide. Just, I think, a few quick things. I think it's great to have so many healthcare providers in the room, because you can be very powerful allies to us in expanding healthcare access and in depathologizing gender diversity and enabling legal gender recognition. And it's important to know that in South Africa, for a person to change their gender on their ID, they still need reports from medical providers, from surgeons or from the endocrinologist or GP who has prescribed the hormones. They need to submit medical reports to Home Affairs before Home Affairs allow you to change your gender on your ID. And I think it's important that healthcare providers know how those letters need to be written in order not to be rejected. But beyond that, it's also important to have you as allies to tell the state that actually it must be a person's own self-identification, their own self-declaration of their own gender that must be the only criterion. Argentina started doing that in 2012, saying a person can self-declare their gender and it must be changed in their ID by just simply filling in a form. No external medical reports or any other kind of approval from outside needed. Since Argentina, a number of other countries have followed, Malta, Ireland, and so on. And I think the next step in South Africa is to also ensure that self-identification is the principle for legal gender recognition. Then, I think it's important as healthcare providers to see trans and gender diverse persons as representing a healthy gender diversity and communicating it to us. So providing a safe and affirming space that would enable people to feel pride in their gender identities and expressions. So even though trans and gender diverse people face a lot of discrimination and obstacles and stigma in society, that doesn't mean there's something wrong with us. And I think it's important that when healthcare providers speak about trans people, that they don't just assume people as patients or people who should have been better off if they hadn't been trans, but rather see what we bring in terms of gender diversity and affirming that it. And then not to frame gender diversity as a form of illness requiring a cure, but rather focusing on wellness and free development of a person. That's actually what Argentina's gender recognition law says, that healthcare services must be made available by the state for the free development of the person. So it's about facilitating healthcare or providing healthcare services that would facilitate the development of a person's and the affirmation of a person's gender identity and expression. And I think, again, I think there's great diversity within the trans and gender diverse community. Not all of us we are very different, one person from the other. We want very different things. We have very different identities and gender expression. So not to assume that there's a textbook kind of way of providing healthcare services to us. And also not to be normative about what constitute ideal outcomes. Because often I think healthcare providers would say, well, that's, you know, a suboptimal outcome, not a good outcome. But I think it's for the trans person to assess, you know, I think how they feel about their bodies, how they see the outcomes, rather than making, you know, predetermined kind of judgments about what's the ideal outcome. And then just to continue to learn and improve gender affirming healthcare procedures and services, and that would already make you the greatest of allies for us. Thank you. I think, Simon, do you have a PowerPoint? Oh no, it's Linda first. It's Linda. Okay, cool.
Now just learn listening to existing.
Which one? Okay, yeah, I do. Let me just put
5 minutes. Oh, I'm very tight.
Okay. Hello, help. My hands are very slippery. Yeah. Good evening, everyone. I think my session is going to be a bit informal because I just want to speak from the heart and I don't want to make it too formal, basically. Yeah. So my name is Linda Kamane and I am originally from Pietermaritzburg. And I happen to be a trans woman, and I'm a woman in my own right. Well, I'm just going to speak from the heart, what, led me to be here. Well, basically, it's the resilience. I want to tell you guys the importance of having a support structure. I mean, being in a support group. The most important thing, what the important thing is about, being part of a support group. Sometimes we tend to forget, the importance of, support of your fellow mates. And when I'm talking about support, I'm not just talking about sitting in a psychological session with a psychologist or just being with a psychiatrist. I'm just talking about even we as trans and gender diverse people supporting each other and focusing on things around wellness. How does one take care of their well-being, Because, it's very concerning. Seeing my other trans sisters who, I've lost due to suicide, and even this month, I had to deal with 2 suicidal attempts. So, it's concerning. So, what do we do as trans and gender diverse people? I think we also need to take action, in just, supporting each other and working with organizations such as Gender Dynamics. Like, for myself, I can just speak from the heart because I came from Pietermaritzburg. And what I did, because I was a trained counselor, I saw that, okay, I was disowned at home. I didn't have the privileges as my other siblings had. But then I didn't want another person to, having to go through the same thing that I did, So what I did, I decided to provide psychosocial support to other trans and gender diverse people, because I didn't want them to be in the same place that I was in. It was a very dark place, a very dark and lonely place. And fortunately, I happened to, have met a lot of people who provided a support structure for me. Chris McLaughlin, Elma DeFries, among other people, and even being trained by the organization Gender Dynamics before I even started working there. And I was like, okay, this is what I'm going to do for KZN. I'm just, this is in my hands, and I don't want other people to go through the same thing. So, by providing psychosocial support, having support groups, and not just having to talk about things about ICD-10 and, gender dysphoria and whatnot, where you have to, open the book and all that. We just focus on things like, peer-to-peer support. How does one, for example, when transitioning, which might, be a term that actually transitioning, it might be a term that might work for other people, but then for me it didn't work. It's not a part of me because I affirmed at a very young age. So I wouldn't say that I transitioned from male to female, because when I say I transition, when one says I transitioned, it means that I identified as a man before or as a boy before. But for me, I've never identified. But then, that's for me, we are all different, just like Estienne said. So the support that I was offering was around, even like peer education, education on, well-being, on, how to take care of yourself, even applying makeup, even for trans men, things like binding, how to bind safely, how to tuck safely, Those are the things that we as trans and gender diverse people should be, educating each other, and not just having to, complain and, rely on healthcare providers. We also need to take the initiative, and also taking care of our well-being. And since suicide rates are so high, what does one need to do? How does another person support, a sister or a brother, instead of just, focusing on yourself? But then, unfortunately, not all people are like that. But then, how do we utilize spaces and use resources like I did when I used resources of one of the organizations in KZN in order to provide for trans and gender diverse people, Yeah. So what we did is also with even the support group that I was in with Chris McClarkin, a psychologist, we also provided even emotional support, and even having a person being the ambassador for another, going to, for example, Endocrine Clinic, because, your way to navigate around, the places and, which places to go. Like, for example, when I went, first day I went to the Endocrine Clinic, I had to do physical examinations, and, having, coming from, sexual abuse and, all that, it was, it broke me, because, I had, these doctors like touching me, and I was dealing with distress, even though it was not perverted, but since I had the support of my brothers and sisters, I was able to pull through, So that is the most important thing, even for us to like support each other and also work with the healthcare providers themselves, because not all of them are against us. And then even, I can like point a few. There's even Kevin Adams, who does surgery, and hopefully Kevin can do my surgery also one day. So, and hopefully there'll be someone here as well who might be able to, maybe Kevin can like, yeah. So I'm like motivating. Yeah. Yeah, so I mean, those are the things that are very important, because, some of us don't have families that support us. So it's very important for us to support ourselves as well. Even like at institutional level, like UCT, we, having, support groups, and even those little NGOs that we always have, adversity and all that. It's also those little things, it's those little things that matter, and they're very important as well. So, yeah, that's what I just wanted to share. It's not much.
Best practice, yeah. Yeah. Okay, well, I know there are a lot of us who are wanting to talk this evening. I normally speak for an hour and cover everything. I normally do 101 in transgender or gender diversity, and Estienne's given you, I don't know if it's 701, but I'm just going to touch on, I was told 10 minutes, which is going to be quite difficult, but I'm going to touch on some of the things that I think might be useful, particularly for people who don't understand transgender and gender diversity, because for most people who are cisgendered, this is a completely new topic, except if you're very young. I work at Red Cross, where I set up a clinic in 2012 for people under the age of 18 who have gender diversity. And I was amazed, how quickly things are changing at schools in South Africa, and how young people do understand gender diversity in a way that people of my generation don't at all, unless they happen to have a transgender child. Transgender people themselves are streets ahead of everybody else in their understanding of these things. Usually when young people come to the clinic, they educate me on who they are and on transgender. I happen to be cisgendered and knew nothing about this topic until I started seeing young people with these issues. So essentially, these are the areas I normally cover in the talk. And I'm just going to go on a few of these issues which I think might be of interest. Essentially, the incidence of transgender, we used to think it was something like 1 in 30,000, but more recently it's looking like 1 in 200. It's much more common than we thought it was. And the reason for this, and this is in young people, we think is the media. That doesn't mean you immediately rush to switch off your television sets and stop your children having access to the internet. It just means that young people are understanding who they are at a much younger age in terms of gender identity. And that's a really good thing, because what we can do for them can completely change their lives in terms of a much more healthy outcome for the long term. Essentially, without the right help, about 50% of teenagers try and kill themselves. And that's really due to the prejudice in society and the terrible pressures people put on these young people. Going through puberty, being cisgendered or happy with the sex you are is bad enough. That's enough to drive quite a lot of people to suicide. But going through puberty in the wrong body is definitely very difficult. And perhaps this exercise is useful. If all the men here start to think that, or who identify as male, that they start to grow large breasts, and these breasts are not going to go away. They get bigger and bigger every day. And the women here start to think of growing a beard tomorrow, and that beard, every time you get up in the morning, your beard gets larger and more obvious, and no one around you understands why this is bothering you. Most of us would be suicidal within about 3 days if you knew there was nothing you could do to change it. Now, for young people who are terrified even to tell their parents, who are often very supportive even of gender diversity, it's incredibly stressful to have to deal with this on your own. So one of the big questions that people want to know is, where does this come from? What are the causes of this gender diversity? Originally, if you said you were a man in a woman's body, you were sent to someone like me or an analyst, because psychiatrists thought you were mad, basically, and something went wrong in your childhood. Your mother was overly close or your father distant, and really we needed to put you on a couch for a number of years and sort out all of your childhood trauma. And actually they thought the same things for schizophrenics originally. It was overly close mothers and distant fathers, and once that was disproved, it moved on to gay and lesbian people. They used to think it was due to parenting. We know that's nonsense today. And then it moved on to transgender people. So parents are blamed for allowing their children to perhaps play with dolls when they shouldn't have, and a whole lot of nonsense. And actually from the centers who used to think that was the case, they did a huge amount amount of research in trying to find the causes of transgender in terms of the environment, in terms of child rearing. And they proved completely conclusively that there is nothing to do with parenting that affects who becomes transgender and isn't. So even if you desperately want a daughter and have a son, and you dress them up in dresses, you do everything you can to convince them they're a girl, they are not going to be a girl unless they have a female gender identity. In terms of where it does come from, it's probably biological. The first hints we got from this was from congenital adrenal hyperplasia, which is a long fancy term for female babies in utero, in their mother's wombs, who are exposed to a much higher level of testosterone, and a far higher proportion of those babies turn out transgender. So they're born with female bodies, but they feel they're actually males later on in life, or from when they can express it. So that got people thinking maybe they're not just mad, maybe this is something to do with hormones, and actually they don't have a choice. And today we have brain scans that can look at people's brains. And if you look at male versus female brains aren't blue and female brains aren't pink. But actually there are differences between the two. Some bits are bigger and some bits are smaller. But it is also a trend. It's not like every female brain looks exactly like this and male like that in those parts. And guess what? If you look at transgender people's brains, they do actually follow the opposite trend. So that's pretty conclusive evidence for people who want the evidence. I would argue it's rather sad that we have to ask for evidence to actually believe people in what they're expressing. But for many people, particularly more biological people, which I'm assuming a number of you people are, it is a useful thing to know, that actually the best evidence is that it has zero to do with the environment. And this is very important because prejudice is what this area is all about. Estienne and his colleagues are all talking about depathologization and stop being prejudiced about these people. And it's interesting because I also see the intersex kids at Groote Schuur. Those are people with bits of both bodies. And for them, the general response of people is, ach, shame, let them decide. They've got a bit of both. But when it comes to transgender, often everybody has a very strong opinion on what this person must be. And actually, it's a very similar condition as far as I'm concerned. And you actually should listen to your patient and understand from them. There have been a huge amount of terms on the overheads, many of which you'll forget and won't necessarily remember. I think the important thing, particularly if you're a clinician, is just ask the patient how they, or the person you're talking to, they're not necessarily a patient, how they like to be referred to. The young people I see, I also see adults, they always educate me on how they like to be termed or what pronouns or whatever, and it changes every few years anyway, so whatever I tell you today might well be out of sync. But gender diversity is actually quite a nice term because it's unlikely to get pathologized. So in terms of what do we do for these people, there are these guidelines which will be talked about more, but essentially with young people, before the age of puberty, they want to socially transition. They want to usually, but I have to listen to what does this child want, and that means things like they want their gender expression to come in line with their gender identity. I'm just going to put this slide up. Estienne's talked about it before, but to remember, I like this slide because it's very easy to look at. There are 4 axes, and one is the top one is gender identity. That's who you feel you really are. Then there's gender expression, which can be male or female. A tomboy is a girl who likes male gender expression. It doesn't mean they're transgender. Then you get the sex, and then the sexual orientation. And each person I see, I need to find out who they are and where they fit in on that spectrum, because they can be anywhere along that spectrum. The whole binary view of the world, that you're on either male or female, is completely outdated, although most of people do tend to identify that way, because that's the way we've been raised and we think. But I think as time goes on, and I see it in young people, they are able to say, I feel mostly male, but maybe 10% female. Now, this doesn't mean this whole area is just a trend, that people are being fashionable and turn up at the Transgender Clinic, I can assure you it takes an enormous amount of courage to actually feel that you want to change something about your gender identity. There's a lot of nonsense in the press about this just being a fashion. I can assure you it's usually involves suicidality at some point before you actually come out to friends and family of saying, I need to change myself, this isn't who I am. So in terms of what I do is I do an evaluation with the young person and their family, and then usually the young person themselves, I see people from the age of 3 to 18. The young person themselves knows exactly who they are and can tell me that in age-appropriate language, in fact far more age language. They're far more mature than their chronological age. So then I support the family in educating them, helping them understand where this is coming from, it's not their fault, and how best to support them. And in terms of how best to support them, in the old days, psychiatrists used to try and get young people to conform to norms. So trans boys, those are biological females, would be put into frilly dresses and made to act more like a female. We know that's rubbish today, and that's just more likely to make them depressed and suicidal. We support them in their gender expression wherever they are. Often these young people have problems with anxiety, depression, other psychological problems, and we find if we support them in whoever they are and get their family to support them, all those problems go away literally overnight. There's almost nothing in psychiatry where you heal people so quickly if you just listen to them and support them. Then my job is if they're teenagers, in the old days, they had to wait till they were 18 to get the hormones because doctors were terrified of intervening and have people change their minds as to who they felt they wanted to be, and then they couldn't reverse it. And I'm going to try and cover this really quickly, but essentially a Dutch team were kind of wild enough to feel, well, actually, if by the time they're 18, half of them have tried to kill themselves, maybe that's not such a good reason to wait. And they first gave hormone blockers, which put puberty on ice. It stops it developing further, and that at least stops people killing themselves if you know you're not going to go any more down the wrong path. And then they gave cross-sex hormones. Which are, if you're female, getting testosterone, for example. And the results were unbelievable. I didn't understand this until I got involved in this area. If you get somebody young enough and you put them on the right hormones, they will completely pass as the opposite sex. Now that's really important because part of the big difficulty for transgender people is they go through life with people misgendering them. For some reason, people feel that if you're not quite sure if this person is male or female, you're allowed to shout out tranny, ask them what genitals they have in a supermarket without knowing who they are. You can't believe how horrific life is to be somewhere in between for many people because society abuses these people, and often they end up having to be prostitutes, not because they want to be prostitutes, but because they've failed to get a job in anything else. Now, if you get them young enough, actually what we see when we decide if someone's male or female is not their genitals. We see their body fat distribution and all sorts of things in their face that we're all expert at deciding on and judging, even though we've never been taught how to do it. And these young people completely pass as the sex they feel they are. So the results were, firstly, that none of them regretted having gone on the hormones, and their mental health was as good as a normal population. And as a result of that, every clinic in the world that works with these young people follows the same protocol, and we do that at Groote Schuur as well. And I won't talk more about the endocrine bit, but my job is not as a gatekeeper, but to make sure that the person is transgender, which frankly is quite easy. Within the first session, if I just make it clear to the young person, I'm not judging them, I'm going to support them, they tell me right away who they are. A few need a bit of time to tell me that. And then, but my work is with the family to get them on board, and then I refer them to the endocrinologist if they are already in puberty. Kids don't need any of this. And then surgeons come later, but some of them need top surgery if they're teenagers and they've got large breasts. That can also be difficult if you're a boy. And I think that covers enough for now. Okay.
So it almost feels like this turns me into a bit of a cyborg. Does it? Okay, so everybody's still with us? Right. So my name is Neil Victor. He, he's, him. Thank you. Okay. Pseudo-cisgender. So what I'm a clinical and research psychologist. I practice here in Cape Town. I've made, because I was talking to the Little Small Surgical Society, 20 copies of a summary of the 12 guidelines. And I'm not going to spend a lot of time. I know there's a lot of other stuff, and at some point people are going to start fading because the wine's finished. So I'm going to highlight what these guidelines were developed for, but what we kind of think they're probably useful for, given some of the previous work we did. The second thing, I'm going to highlight the kind of 12 guidelines very, very briefly. Those are useful for you in terms of practice. So whether you are a surgeon, whether you're a counselor, in whatever capacity you have to deal with patients and you have to deal with bodies, this is a useful way to start thinking. And some of the terminology that we use here, even as we published it, we realized were already somewhat dated. So also understand the importance of continued professional development in the work that we do as well. And Estienne was talking about body diversity, and it's a conversation we've had, and you'll notice body diversity is not something that's in this title. And then the third thing I wanted to do was talk about affirmative practice. And what affirmative practice is. And affirmative practice is not just a psychological practice, but affirmative practice is a lens, is a way in which you can approach this population, and it's a kind of an ongoing, cultivated lens that you need to work at. Okay. And maybe if there's time, there's a video just for like shits and giggles. Okay. Right. So the purpose of the guidelines is really to provide an affirmative stance, and I'm going to link back to this idea of what is affirmative practice, on sexual and gender diversity, including lesbian, gay, bisexual, trans, which is particularly what we're talking, intersex, queer, asexual, plus. Okay, so that's a political term. We use sexual, gender, and body diversity increasingly, because this is not just about the politics, this is about health provision also. And primarily at psychology professionals more broadly, but what we've seen with the work we've done over the last 7-8 years is that this is applicable across most of sub-Saharan Africa and certainly across healthcare providers. So this is kind of useful to use. It's not the domain of this kind of pseudo-discipline called psychology. Okay? I'll get back to that. So, I spoke about this lens, the glasses that you wear through which you look at. Cultivate means it doesn't just appear one morning when you wake up. You actually need to work at it. Ongoing means you need to work at it continuously, like everything else you do as a professional. So it's an ongoing sensitivity and acceptance of sexual and gender diversity. Some of the there's kind of vague discussions around what this means, but some of the stuff is around that sexual and gender diversity, differences in sex characteristics are normal. Okay, so it moves from the pathology. Estienne kind of started talking a bit about that. Move away from your perception around looking at pathology or otherness, difference, and start thinking around this term normal as Those differences are normal. Contextual awareness. So contextual awareness, understand the impact of the context, such as things like homophobia, transphobia, and the impact that has on the well-being of people and what they're looking for. It's huge. Need to have an empathy with the unique experiences and be knowledgeable about diversity. So when we talk about diversity, and the strange thing is when we teach around sexual and gender diversity, increasingly, somewhat frighteningly, we're not just talking sexual and gender diversity, we're talking diversities in general that we're not dealing with in particular ways. And so some of the stuff we're starting to find is actually pretty useful as a way to think around diversities in general. Okay? You need to be comfortable with your own sexuality and gender to avoid bias. Do yourself a favor, for those that identify as heterosexual, straight, or mostly heterosexual and straight, or somewhat experimenting, but mostly heterosexual and straight, go and check online, Google the 25 questions to ask yourself. When did you first realize you had these, feelings for people from the opposite sex? The kind of questions that are often asked. And when you start around that, so that deals with our sexual orientation issues, but then hopefully it starts sensitizing you to also the issues of gender and moving beyond these kind of issues around gender binary, and also confusing the issues of sexual orientation and gender binary. I had this shocking experience the other day where, as one does, one goes for couples therapy at times, as a psychologist does. So somebody starts spouting their pet theory about the femininity that I as a gay person have to accept. Okay. Rubbish. And this on my time that I'm paying for. Really? The only decision I need to make is if I'm sort of going back to Leviticus and I'm going to stone the fucker or not. That's all. Okay. You also need to understand, and I think Linda, what Linda brought us was some of that amazing resilience. Remember, your clients are not entirely dependent on you to save them. You are not their savior. They have the creativity, they have the resilience to deal with this. You're there to support and assist as appropriate. So clients have the creativity and resources to cope. They do. Deal with and explore the impact of society and significant others, particularly in those kind of sessions, but for those that's maybe in the kind of surgical society, just understand the context within which people have to deal with and be sensitized to that. And your reality is not necessarily their reality or anybody else's reality for that matter. Actively take a positive view of client lives. It's always nice as a kind of a medical professional, even psychologists do that terribly well. Maybe, this kind of neutral, pseudo-neutral, as I call it, kind of position or objective position. In particular cases, particularly when people are faced with such enormous amounts of prejudice in society, you have to take a much more active role in assisting and working with people like that. And you know what? That could be so amazing for you as well, because you learn something every single day. Right. Oh, I do want to play that to you. Okay. So, the 12 guidelines, very, very briefly, starts from kind of broad to much more specific. So it starts with non-discrimination for those of you who hopefully are aware of our Constitution. Maybe, yeah? Okay. Some ethical codes around medical practice. You might recognize non-discrimination as something. Okay, so that links into individual self-determination, and certainly Simon spoke a lot about that. You know what? You have somebody walking to your room, they know better actually. This kind of expert position sometimes, in these particular areas around your training that you have expertise. For the rest of it, actually, that person knows their lives better than you do. So that's important. Enhancing professional understanding. So if you talk about sexual orientation, what the hell do you mean? If you talk about gender diversity, what do you mean? What is it? How does it differ? So the stuff that Estienne spoke about. Normative social context. This lovely kind of post-Second World War kind of thing. 2.1 kids, picket fence, American ideal dream. The nuclear family. Okay? You start needing to ask questions about that. Not because I'm saying the nuclear family is a terrible idea. I should probably stop swearing so badly in such a haloed hall. But because not everybody defines their relationships in that way. Not everybody develops in these particular ways. Much more fluidity that's actually happening out there than this sort of little kind of pseudo-scientific categories that we try to create for ourselves. And yes, fair enough. A lot of science is based on difference, variance, analysis of variance. We understand that. But you know what, people? There's enough statistics of similarity to also make us think differently around the ways in which we construct the ways that we start finding out about these kind of things. Okay. Intersecting discriminations, intersectionality. So if I have a black lesbian from a poor area, it's going to face very different challenges from a white male identified person that's transitioning. You kind of hopefully see that. Oh, and there's many of these. It's not a reality, it's a useful way of starting to understand how privilege, for instance, impacts on healthcare outcomes and healthcare needs. Okay? So intersectionality, stigma and violence, crucial. Also, that's why it's important to listen to what your patient is saying or client is saying. We know that in the mental health environment, there's this kind of thing that's about kind of gender expression and the importance of kind of living the gender that you need to be. But the reality is in some contexts, it will get you killed. It's as simple as that. So regardless of what the literature says about the positive health income, if you die because of it, no positive mental health outcome is particularly relevant. Okay. Multiple developmental pathways. Important. Then there's lots of kind of mythologies around that, and I can spend a whole weekend just talking about that kind of rubbish. But this idea that there's kind of just the simple stages by which one develops gender identity, for instance, this is nonsense. You need to start understanding that this kind of idea of developmental pathways, and I think it's more South Africans actually, in terms of what I've noticed from my international colleagues, we are much more open to understanding actually this fluidity of developmental pathways than many of them are, particularly some of our American compatriots. Non-conforming family structures and relationships. Not that I'm anti-American at all, I'm sure there's lovely people there. Non-conforming family structures and relationships. The necessity of affirmative stance, I've given you that 6 odd points, the lens. Think of the lens always. Ongoing development, sensitivity to and acceptance of. Those are important words. Disclose and rectify, foregrounding global best practice. We spoke about WPATH. Disclosing, rectifying personal biases. Understand your own biases. I'm not suggesting you necessarily change them, or well, it might be nice in some ways, but you need to be honest about that, because those things have impacts on people, and because of that, people kill themselves, they throw themselves off buildings or take pills or whatever. You can use those pills for other things. Continued professional development, key, and that's key part of affirmative practice. Okay, how's my time? Do I have 2 minutes? No. Okay. Right. Sorry, you're not going to see the video, so what I'm going to do, I'm going to leave this here forever is interested in the 12 guidelines. Alternatively, go to www.cisa.com, blah, 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 whatever. Just go to cisa.com. You can go and search for it. You can see the videos there as well in terms of the launch of the guidelines. Thank you so much. I really appreciate your time. Sorry, I need to give up my cyborgness.
All right, everybody. I now have the honor of introducing our representative from endocrinology for this evening. I'd like to welcome Associate Professor Joel Dave. He is a senior specialist in the division of endocrinology and diabetic medicine. Yeah, and he'll be speaking to us from an endocrinological perspective.
Okay, is this working? Good evening, everyone. I think I'm going to spend very little time on the endocrine aspect because it's reasonably simple. And a lot of what I was going to harp on already has been said. And I think the two key features that I hope from the initial part of my presentation will be that this isn't a disease. It's not a pathology. Okay, I don't like calling my transgender people I see patients. In fact, I often discuss with them what I should actually call them. I don't like calling them patients because I don't feel that they're ill. I don't like calling them clients because it's too businesslike. So it's not an illness. I'm going to start off with maybe opening a bit of a can of worms. I've recently been involved, and I'm sure many of you have seen in the news, this hyperandrogenism in sport. And it's calling on people to prove their gender. And I think that's possibly something similar to what transgender people go through. Because the way society has packaged gender, some people know exactly that they conform to what society says is a female. And some people think that they conform and know they conform to what society says that they are a male. But then there's diversity. And if we have a look at these pictures, what do you think? Boys, girls, not. This is a tennis player on the female ATP circuit. I think she's number 200 or 300 in the world. This is a very famous, apparently, I'm not into folk music in the USA, but a famous musician in the USA. And I'm sure many of you might recognize this actress as Jamie Lee Curtis. Okay, so is it quite easy to determine their gender? I see someone nodding. Anyone not happy with what you see there? Can anyone not say what gender they are? Because everyone's happy. Over here, you recognize our legendary female athlete, Caster Semenya. Are any of you not happy calling her a female? Or what you see? Okay, so if we have a look at these people, they're all biologically males. Okay, so if we define gender by what our biology, our genes say, these three, and rumor has it about Jamie Lee Curtis, but the other two have come out and they're quite outspoken. They got a complete androgen insensitivity. So if you do their genetic phenotype, it's an XY. And if you do their testosterone levels are extremely high. Okay, because they have mutations in their androgen receptors such that their body doesn't see testosterone. So it develops as a female. And so this is what society wants us to appreciate with females and males, neatly packaged and very easily separable. But you've seen on previous slides that it's probably not as easily separable as society wants us to say, and maybe what we taught in medicine. And that there's probably a spectrum and a diversity and an overlap of what is male and what is female. And possibly there's also gender neutrality, where someone doesn't want to be regarded as a female or a male, or doesn't feel like a female or a male. And so there's very good and plausible and well investigated and researched ways in which our genetics and our genetic sex is determined. This was recently discovered, the SRY portion of the Y chromosome, that if that is present, it then determines what genes are turned on and what genes are turned off, and it'll turn off all your ovarian genes, and it'll turn on all those that promote the production of testosterone. So if you're someone with an XY and you have an SRY portion, you will then develop as a male. You can see here XY, SRY, you'll develop as a male. You've got an XX, there's no SRY, and you'll develop as a female. But what this doesn't take into account, you've got different determinants. You've got a gonadal sex, a genetic sex, a phenotypic sex, and a behavioral sex. But what it doesn't take into account is brain sex. And it's not sex on the brain, it's brain sex. Okay, and that there's some people that despite genetically having male chromosomes and phenotypically appearing male, actually consider themselves and feel as a female. And unfortunately, society and the way that we taught in medicine doesn't recognize that, and therefore pathologizes that kind of thought. I hope no one's confused. So I'm sure you all recognize Caitlin, former Bruce Jenner, male Olympian, decathlete, gold medalist for America, who's now regarding herself as a female and living life as a female. And these are some of the terms that have been projected to be used by either the World Health Organization or the American Psychiatric Association. Again, I agree with the previous speakers that I don't like this term should go, because it gives a lot of these people a pathology when it's actually not an illness. So just to go on to, there are some well-defined guidelines that guide the hormonal treatment and the medical assessment of people that want to undergo transgender treatment. Again, I want to reiterate what the other speakers have said, is that actually I think that there's no one yet an expert in this. I think the biggest expert is the patient, and or the person that comes to see you. And often they are extremely well read on all the hormonal aspects and the adverse effects and side effects of the drugs and the dosages. So these are the American guidelines. This is what we are trying to achieve with therapy. And the main thing that we're trying to achieve is basically to reduce the endogenous hormone levels that they have, and then to replace those with hormone levels that will affirm their own gender identity. And that we have, unfortunately, numerous potential side effects to the drugs. So in seeing these people, it's very important to take a full history and to screen them for any pre-existing conditions that may complicate the hormonal therapy that you're going to be placing them on. There are multiple options for treatment. Essentially, those that are transgender females are going to be put onto some form of estrogen-containing medication, and those that are trans males, they're going to be put onto some form of testosterone-containing medication, or we've got some medications that can act as androgen blockers. This didn't come out very well, but this is just those that we have access to, and it's our protocol in the Transgender Clinic at Groote Schuur. And this is what can be expected, and this is exceptionally important to discuss with the person that you're seeing. They've often waited many, many years to get as far as they have at this moment in time to see an endocrinologist, and they're wanting things to happen very quickly. Unfortunately, it doesn't happen quickly. It starts with about 1 to 6 months, but then you can see here that the maximum is going to take quite a few years. So it's a slow and nurturing and supportive process that you're going to be going through. This is masculinizing effects. These are the changes that are going to happen. You'll probably recognize those as some of those that you associate with a man having. And there's also feminizing effects. Again, you can see it's not a quick process, often taking many years to achieve what we would regard, or what you would regard in society as what would make this person look like a female. So I think that was just a quick step through, because I'm in the supportive act for the main act, who is Dr. Kevin Adams. So with that, thank you for listening. Is yours on here?
Yeah.
Is yours here? Is this yours? Is this yours?
Yeah, it is.
So let's put yours in here.
That's fine.
Oh, is it there?
Oh, it should be.
Okay. Do you want to use this?
Yeah. I suppose I should. I don't have to shout. Right. Can everybody hear me? Okay, good. I realize we've just run out of time, so we can always reschedule the rest of it if you guys want to go home. Feel free to leave. Okay, thought I'd try. Okay, so I'm Kevin Adams from Department of Plastic Surgery. I'm very honored to be working with the rest of the guys in the Transgender Clinic. And in fact, we had a combined clinic this afternoon. And I realized for the first time that we've actually been running for almost 10 years, which is quite an achievement, I think, because certainly when we started out, it was a lot less formal. Okay, so basically, what I'm going to do is try and give you guys a guide to transgender issues. As Joel said, everybody's touched on topics like this. But I want to just emphasize, all the clever people have spoken already. I'm just a surgeon. And so I've got a much more simple way of approaching things. And this talk I've given multiple times. But I think it's useful to clear up the gender dysphoria thing in my simple way. And we'll look at the combined clinic. We'll skip over that because we've talked about it a lot. Legislation W path we've touched on as well. We'll talk about the transition process and the surgery. And if anybody's particularly squeamish, there are some slides that warn you to close your eyes. And what's going to be happening with the medical aid issues. And interestingly, what's going to be happening, we don't know, with national health insurance. Okay, so firstly, transsexualism is an old term. It's last century, and it shouldn't be used because it confuses people, like me, okay? So if I hear sexual something, I start thinking it's what you want to do when you get jiggy with it, okay? And that's got nothing to do with being transgendered. So the way that I still try and explain to people the differences is that your gender is how you like the world to see you and interact with you. And it's got nothing to do with your sexuality. And it is tradition in the medical literature to talk about it as sex, but it's got nothing to do with gender, okay? I'm confusing myself as well. So, sexuality is essentially what you want to do on Saturday night when you've been down to Stones and you've had a good time and you've hooked up, okay? It was a long time ago and it wasn't called stones. Okay. And transitioning is the pathway that a transgender individual goes through, which is specific to them. Okay? I've also evolved a lot. I like what you were referring to, Neil, is you need to reevaluate where you are at all stages of your transition through life. Okay? And there are a few things that I'll touch on in a little while, but the process is different for everybody. And probably the best starting place is, firstly, to recognize that the person sitting across the desk or on the bed with you is there for your help. Okay? And my job as a surgeon is not to decide what is best for them. My job is just to give them good information. Simply because those choices are theirs to make as an individual. And in a lot of ways, there are a lot of analogies here to apartheid. Okay? It's all about us and them. And we're trying to move away from that. So it's a good analogy to have. Why do you need to make decisions about whether what somebody else chooses to do with their life or the challenges that they have in their life, you have a right to comment on? You don't. Okay, so for the trans women, to help women understand what trans women go through, if you think back to those days when you were 10, 11, 12, and you were looking forward to becoming a woman, okay? You were looking forward to certain things happening, like developing breasts, getting feminine curves, perhaps not, okay? But instead of those things happening, you get the beard, you get the hairy chest, and one of my patients actually said to me, actually for her, the biggest issue was the really hairy legs, because she was a sports person, she liked doing triathlons and things like that, and having the hairy legs just really pissed her off, okay? And then you get the large hands and the feet, so you can't be dainty and petite when you've got size 11s, okay? And then your voice deepens, and as Joel mentioned and Simon mentioned, you actually start to feel like your body is letting you down. And that's supposed to be the one thing that you can trust in life. And if it's letting you down, it really does cause problems. And using men's bathrooms, we'll talk about in a little bit. So for the men in the audience, imagine going back to that time when you were waiting to get a little bit of hair on your face and getting a bit of hair on your chest and all of that, but instead your breasts start growing. And as Simon alluded to, they just won't go away, and it just keeps getting worse and worse. And then to top that all off, all that embarrassment, you start getting periods, which is a huge problem. And one of our, well, I hope it's peculiar to South Africa, but we also have this thing called corrective rape. And if on top of that you end up being pregnant as well, you can kind of understand what's going on. So there was a big campaign, and this actually predates Trump. Okay, so this was in the Obama days. But there was a big Republican drive to make birth gender women use women's bathrooms. And this guy was an activist and posting these kind of pictures on Twitter saying, do I look like I belong in a woman's bathroom? Blah, 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 blah. And essentially all I want to do is go and pee. And that is true for the vast majority of people. And, you know, that kind of environment is just wrong. And nobody deserves to have that kind of thing foisted on them in day-to-day life. Okay, so how did I get here? They asked me to. But again, and this is, I think, the beauty of UCT, it's actually being taught to think. So way back when I was a plastics registrar, this was one of the trans women that had a vaginoplasty done. And to me, that just didn't look right. Okay? And over the years, talking to the endocrinologists and the psychologists, the psychiatrists, as we met in the passageways, we began to think, well, we needed to set up a combined clinic because this was a very complicated problem and none of us were actually managing it particularly well. So just so you guys can compare it to the other photos, I don't know how well it's projecting, but basically what you're seeing there is the remains of the labia. What you can see there is the glands from the penis, which it was thought that if you put the glands up at the top of the vagina, then it was more likely that you would be able to self-lubricate. And if we've got time, we'll talk a little bit about that as we go on. But, and I don't know if you can see the date there, but that was back in 2005, which was a long time ago. Okay. Then this is one of my male patients who probably was the person who got me started on this journey. And he emailed me again the other day, and I've got to answer his email still because I get too many of them. But this is in the days when I was an arrogant arsehole, basically, okay? And I thought, well, okay, he wants a penis, he's got issues, and he's clearly mad. And so we decided to make a penis for him, and we did a thing called an ALT, an anterolateral thigh flap, where we take skin off the anterior thigh, and we turn that into something that looks like a penis. But it failed. Okay, so this whole thing necrosed, and then we had to treat the wounds. And I thought, okay, right, we've mutilated him now. Surely he's going to get his head right and decide that he's going to move on with life. And the last thing he asked me before he was discharged from hospital is, when's my next operation? And I thought, that doesn't sound right. You know, it's not what I was expecting. So we organized another operation for him. We took an ALT from his other leg, and strangely enough, that failed as well. Okay? And whole process again, and then he said to me, when's my next operation? And that was when the penny started to drop with me, that actually all he wanted was a body that he could live with. Okay? And he was willing to go through all the scars and everything else. So that was the scar tissue on top there from where we tried to put the penis. And eventually we got him in and we did a radial-free forearm flap where we take skin off the forearm, we convert that into the neo-urethra, that gets tubed inside. We'll show you some more pictures in a bit. We fold that over on the outside, and it worked. And he was ecstatic. And that's kind of what started it. So before the combined clinic started, in about the late 1990s, we just stopped offering the service at Groote Schuur. And because we had all these patients who were demanding access to healthcare, we got to the combined clinic. And I actually had patients come to me and said, look, I don't care if you experiment on me, I just need to have the surgery. And that kind of pushed me on the path that I've now gone down. And so it's a big team. A lot of them are here. And one of the biggest things I want to just emphasize here is gender dynamics. They were instrumental in shaping the way that the clinic developed. And I just want to emphasize to you guys as well, you know, the old days of thinking that you were a divine being because you were a doctor are gone, okay? And as long as you are able to partner with your patients to hear their problems and solve them together, I think we'll get much better outcomes. Okay, international standards we talked about. The old Harry Benjamin thing is still promulgated in various parts of the country which will remain unnamed, and that is not true, okay? There are a lot of faults with it, but we'll talk about it. But what I want to stress is that that came out in 2001. It was about 22 pages. Then WPATH came out with the 7th edition in 2011, which is 120 pages. But the brief précis of it is that doctors should actually get back to basics and do what they're supposed to do, which is help people. And realize that that's essentially what we need to do. We don't need to decide, we don't need to give them hurdles. And life is difficult enough being transgendered in the first place without having doctors causing shit in your life as well. I like your language. Okay, so at Groote Schuur, all patients have a psych assessment, again, not because we think that they're mad, but because it's good medicine. There are situations where patients do have psychiatric, psychological issues, and they need to be attended to before we start doing other things. And I've been in a situation as well where patients have been manic, okay, with bipolar disorder, and they've made spur-of-the-moment decisions about things. The one thing I can promise you about an operation is you can never undo it, okay? You can do another operation which gives you more scarring, but there is a lot of benefit to being the last person at the back of a whole lot of other people that you can blame when things go wrong. So the big benefit to the current SOC 7, Standards of Care 7, is that we've realized that most of our patients are not mad, and that psychotherapy is now recommended, but it is not a requirement, okay? Yes, it is very stressful for anybody going through a big process like this. But again, one of the big things that we've done away with, and a lot of people around the country still find themselves needing to do, is a real life experience. So prove that you actually want to be who you say you are. And there's no need for that with the Standards of Care 7. Once they've had the psych assessment, and our psychologists and psychiatrists more often than not find that they're just going, yeah, you're transgendered. They can then start their hormone therapy, and internationally, in the States, you still need to be on hormones for a year before you can have any surgery, okay? That doesn't make sense to me, particularly if we're talking about breast surgery, because if you have surgery on your breast, it doesn't impact on your hormones at all, okay? So, and because of the whole corrective rape issue, it is kind of a priority for trans men to have their mastectomies done, but equally so for trans women. But there are other issues with taking out your testicles or your ovaries if you aren't on hormones. And again, I've had queries from patients saying, look, I really am worried about taking hormones. Do I need to do it to have surgery? And I'll go, well, actually, the point is that my job as a surgeon is to tell you that it's probably a good idea for you to go on the hormones. But if you don't want to take them, then, I know, just saw you there. Then you don't have to take them, okay? And once they get referred to plastics, I talk to them about the various surgical options, and unfortunately the waiting list policy, and we'll talk a little bit about that just now. So legislation everybody's talked about already, and that's a copy of the letter that I now give to patients who've come to the clinic. And it's, again, and I'm also a government employee, but what I tell my patients is that they need to realize that Home Affairs people are just government employees as well. They're not particularly bright, okay? So this is so that they don't get confused. But in terms of the Act, it says that so-and-so is a patient of mine, they've had gender reassignment surgery, and what the Act actually says is that a medical or surgical transition is sufficient to warrant changing your gender identity and descriptors. So as soon as you've taken a dose of hormones, you're entitled legally to change your gender descriptors. Okay, Simon touched on the incidences, and it's becoming a lot more common. And I think a lot of it is actually the internet, access to information, knowing that there are other people who feel like you. And often when I ask my patients how long they've known that they're transgendered, some of them misunderstand the question and think I'm asking, when did you find out there's a name for it? But everybody that has surgery has always known. And that's kind of the take-home thing. So the Triangle Project is great because they do the support groups, and they get us to talk at them. The psych assessment we've talked about and everything else. But the other important thing for patients to understand is before they start their hormones, they need to think about whether they want to sperm bank or ovum bank to have their own genetic children. Simply because the chances of them being able to do that once they've started on the hormones decreases dramatically. And again, the vast majority of people go, nah, if I want to, I'll adopt. But again, it's an important point. It's not your job as a doctor to decide for them. It's your job to give them the opportunity to make the decision. We talked about changing ID and all of that, and other procedures to do whilst awaiting surgery, laser depilation, removing the beard for the trans women, foreskin preparation, and so on. Voice coaching is something we were talking about in the clinic today, and again, to come back to what Simon was talking about and Joel, the big problem with a voice is once you get to my age and your thyroid cartilages have matured and ossified, the chances that you're going to change your voice with surgery or anything else reduce dramatically. So the pitch that you can achieve and everything else is much less modifiable. Whereas if we're thinking about preventing puberty in the first place, outcomes are much, much, much better. And it's still, we're still having discussions with Discovery about why making people wait until they're 18 is not a good idea, but that's another talk. Okay, so we talk about surgery. Guys were talking about top surgery beforehand, and that's transgender parlance. Breast surgery is top surgery because it's on top. And bottom surgery has got nothing to do with your butt. It's pelvic surgery. We'll talk a little bit about that as well. So for the majority of trans women, there is some breast development once they start taking estrogen. And they're just like everybody else. You get women with small breasts, you get women with big breasts. Trans women may develop big enough breasts, but a lot of them don't, okay? And so, and again, they're a lot like other people. Women coming to us for breast augmentation always want to be bigger than we can make them. Women having breast reductions always want to be smaller than we can make them. And that's just human nature, okay? But if we need to put breast implants in, we offer that. With the average breast augmentation, a lot of people do it as a day case. You go home the same day. I tend to keep all my patients overnight in case they get hematomas. But with a breast augmentation, even if you're in an office job, you can be back at work within 2 weeks. Again, depending on anatomically where we put it. Back in the early days, we would do an orchidectomy at the same stage. If they've been on their hormones for a year, and the waiting list is long enough now that that's not an issue. But because we've got such a over demand for the plastic surgery operating time, I'll often refer them to the urologist so that they can do some orchidectomies there. Okay, and we've only had 2 patients that I can think of in the last 10 years where the breast development hasn't been adequate on estrogen, and we've tried to put breast implants in and we haven't been able to because the tissues are just too tight. With them, we've gone and put in a tissue expander and then come back a bit later and put breast augments in. But that's the kind of result that we can get. And most people are over the moon with them. And areola size tends to increase with the increased volume. But again, everybody's different. Okay. With the vaginoplasties, the important question is, what things do you want to make and what things can you afford to get rid of? So Andre van der Merwe, who's the urology prof at Tygerberg, was contacting me a little while ago before they did their first penis transplant, saying, can't you give us penises? And I said to him, actually, in all honesty, no, I can't, because the only part that we don't use is that little offender over there, okay, which is the corpora cavernosa, that's the erectile tissue. But the skin, we need to make the vagina with. The part of the glands is what we use to make the clitoris. And to maintain erogenous sensation, we need to keep that attached to the nervi erigentes, which are running in that bit of tissue over there. So there's an artery and several veins in along with that. That's probably the most technical part of the operation. So most patients have erogenous sensation afterwards. The catheter there is going into the urethra, and we shorten that. We turn the foreskin inside out, and we put that in down there. And we used to do labiaplasty as a planned procedure a bit later on. I've got a reasonably good idea of what most people want now, so we tend not to need to do that. But we can achieve results that look a little bit like that, and I'll talk a little bit about the hair removal in a second. So this is the same patient who didn't have adequate hair removal, but you can see that there's the clitoris, urethra's over there, vagina's over there, but you can see that there's hair coming down into the vaginal cavity. And that creates a bit of a problem in the long term, because if you still have hair follicles there and it's a moist environment, you can get folliculitis, you can get infections, causes problems with smell. Remind me, we might have a quiz at the end to see who the clever guys are. Okay, so for the trans men, the big issue is mastectomy. We have a chat with them about scars, the risks of nipple necrosis, and we decide about nipple size. What do we need to do about the areola? Do we need to make it smaller? Do we need to make the nipple smaller? And same patient, because he'd been binding, so in other words, trying to make his chest look flat, and he'd been putting a binder around his chest, that had elongated the breasts, which gave me a bit of a technical issue in trying to get the nipple from there all the way up to there. And this is the result. We got his left nipple actually necrosed. But I still use this picture to illustrate to patients that if you treat it properly and you wait for it to settle down, the nipple does repigment and often looks like a fairly good nipple afterwards. And same kind of body build, but in general, having to reduce the amount of skin that's there, we use what's called a wise keyhole pattern. We move the nipple up there, and the scars generally settle down quite well. Okay. So, to create a penis for the trans men, we do a procedure called the phalloplasty. I've shown you some of this already. This is a free radial forearm phalloplasty. And what you can see there is that we've taken that bit of skin, stitched that to that, and then folded that underneath. That's what it looks like. The catheter is going through the near urethra. The radial artery and cubital vein are still attached at that point. And we then move that down, and that's what we end up with. The radial artery is connected to the inferior epigastric. The vein is connected to the long saphenous vein. And when it works, it's fantastic. But if you have a problem with the anastomosis of a thrombosis or something like that, it tends to be a bit of a problem. But patients love it when they wake up the morning after the operation because it swells and it looks magnificent. But within about 3 months, once the swelling starts to settle down, they start getting a little bit worried because it's a lot less impressive. But again, maintaining erogenous sensation, when guys started doing these operations first, they just left the clitoris in the midline and created the urethra over it, which is a bit of a problem. So what we've tended to do is to move the clitoris to one side or the other so that we can maintain erogenous sensation. But what you can see in this picture is that we've got a lengthened urethra, so we've created a near urethra coming from the urethral orifice down there up to here, which is where we connect the new urethra in the radial forearm flap. One of the big issues is scarring, and this patient is now married, living in the UK, and if somebody asks him what happened to his arm now, he just says, look, I had an issue when I was a child, burnt my arm, I had to have a skin graft. And most people go, okay, cool, carry on. But it is a big issue, and it does create quite a disfiguring scar. So, same patient, after the op. Back in the original days, we would come back about a year later, we'd put testicular implants in, and then you get a bifid scrotum because there's a gap in between the labia minora there. And then once that has settled down, we'll come back and create a normal-looking scrotum. but we tend to do it at the same time now. So this is the alternative, is converting the clitoris, because it has all the anatomical features that we need in a penis, into a penis. So it's got erectile tissue in the form of corporal, although they're much smaller. It's got erogenous sensation at the tip. The only issue is that we need to lengthen the urethra again so that you can pee from the tip of the penis. And so what we need to do is lengthen the urethra to do that. We do the same kind of thing excuse me, in hyperspadia surgery, where the urethra comes out sometimes at the base of the scrotum, sometimes somewhere along the shaft of the penis, but we lengthen the urethra the same way. But the kind of take-home message for trans men is, and the other thing I forgot to mention, we lengthen the clitoris the same way that we do for penile lengthening, which we do for septic circumcisions. And if you guys are prone to watching movies on the internet, a lot of porn stars have big penises because they've had a penile lengthening. The big problem with it is that the scrotum ends up moving along the shaft as you lengthen the penis as well. So we can lengthen the clitoris by about 4 to 5 centimeters. But the take-home message is it's essentially not going to be big enough to have sex with. So same patient, clitoris that size, we end up with a penis that size, but it looks a whole lot more natural. Any questions before we carry on? Yep.
You mentioned gender diversity, so people aren't necessarily identifying female and they're sort of in the middle. What are the treatment options for those kind of patient types?
The treatment options are to think about things well before you make a decision, and certainly before making a decision about surgery, because once you've had the surgery, undoing it is a bit of a problem. So I've had patients say that they want breast augmentation, but they want to keep their vaginas. Fine. I've had patients want mastectomies, and that's it. My job as a surgeon is to just tell them what surgical options there are available, and the complications that can happen with them, and for them to decide what would be the best thing for them, realizing that once you've had the surgery, you can't really change your mind, because then you're living with the consequences of that decision. Does that kind of answer your question? Okay. So, one of the sexual health issues that has taken me a while to work out in my head as well is, if you've lived for 30 or 40 or 50 years with an aversion to your genitalia because they're just wrong in your body, I think sometimes it's a doctor issue, thinking that as soon as you've got the right genitalia, you're going to go out there and use it because you've got to have sex. Tends not to happen.